This is Focus on Your Health. It's brought to you by Kingman Regional Medical Center in historic Kingman, Arizona. I'm TG LaFredo, and this week on the program, it's the Best of 2025, Part 1. I have been producing and hosting Focus on Your Health for over 13 years now, and even after all this time, it's still a joy to bring you information and stories from KRMC and the community it serves. We've been through a lot together, from the early days on the KJAZ Radio Network and the Arizona Community Radio Network, and later KNTR Talk and an ever-growing archive on YouTube. Radio is indeed alive and well, and our local connection makes it that much more special. In an age of artificial intelligence and dubious facts, we are real people right here in Mojave County doing our best to bring you worthwhile information on health and wellness. In 2025, we dedicated significant time to conversations about cancer, about prevention, treatment, and recovery. In September, we aired a conversation with Dr. Edgardo Rivera, Director of Oncology Services at the W.L. Nugent Cancer Center, and Ray Timm, his lead LPN. We talked about genetic testing to detect cancer. The topic can be complicated, and it can be personal. But I think you'll find Dr. Rivera and Ray make the conversation easy. Dr. Rivera, how common is genetic testing for breast cancer?
I think we need to really understand first what's genetic versus what's hereditary.
Please.
Right?
Yeah.
So there's a difference between having a genetic cancer versus hereditary cancer. So all cancers are genetic, right? So remember, cancers are just normal cells that change over time. They go through genetic mutations and they lose their ability to die. So technically, all cancers are genetic. The question is whether the cancer is hereditary, whether the person was born with a genetic predisposition to develop cancer, right? So that's the difference. And that's the importance about genetic testing and understanding the difference between something that is genetic versus something that is hereditary.
Yeah, that's a great point. Genetic and hereditary in other contexts are sometimes used interchangeably, right? Or not
They
so
are,
much?
and some people sometimes get confused about that.
Yeah.
The reality is all cancers are genetic.
Right.
All cancers are caused by some sort of genetic mutation. Most of them are caused by either the environment, lifestyle. Smoking, for example, is the most common cause of lung cancer. Diet, obesity. That's different from being born with a high predisposition or a hereditary predisposition to develop cancer.
Understood.
Most cancers are not that way, so most people are not born that way. But there's still a small percentage of patients that have a high risk of developing certain type of cancers. We do want everybody to get screened for breast cancer using mammograms.
Correct.
The question is, when you talk about genetic testing, who's the right person to have genetic testing and who's not?
Well, who is?
Exactly.
Well, who is? I'm asking you because
you're asking
the
me.
doctor.
Okay. So normally, there's a whole criteria that we use, right? There's some cancers that are definitely more common in which there's going to be some sort of a genetic predisposition, in which there is a hereditary predisposition. Normally, you talk about cancers like breast cancer, ovarian cancer, colorectal cancer. You don't talk about that in lung cancer, for example, because we know that 95% of lung cancers are caused by smoking. Same thing with bladder cancer. Number one cause of bladder cancer is smoking. But there's other cancers like breast, ovarian, prostate, pancreatic, and colorectal. All those not only can have a component of being developed by your lifestyle and environment, but there's also a small percentage of patients that were just born at a higher risk, right? So the question is, who is the right person to be tested? We have the American Society of Clinical Oncology, and every year they publish these guidelines that we use in terms of who should be the right person to undergo genetic testing. We know that most cancers tend to happen in people as they get older. You don't see normally somebody with breast cancer in their 20s or 30s. Those are not very common. Most breast cancer happen between age 50 and 69. So for example, if you have a patient that comes and see you and is somebody who's younger than 50, and especially if they have a very strong family history of either breast or ovarian cancer, or even a history of prostate cancer and pancreatic cancer, or they have a personal history of a different type of cancer as well, like ovarian in the past, those are the patients that you have to think about, do they need to have genetic testing? There's also specific type of cancers that it really help us have an idea whether they should be tested or not. The perfect example is when a patient comes with what we call a triple negative breast cancer. The patient has already been diagnosed as a triple negative breast cancer. That is a very aggressive type of cancer to have. Those patients nowadays are recommended for all of them to be genetically tested. Because if you are born with a genetic predisposition to develop breast cancer, the likelihood is that you're going to have a triple negative breast cancer. So just because you have a triple negative breast cancer doesn't mean you have a genetic predisposition. But if you do have a triple negative breast cancer, you definitely should be tested. The guidelines now recommend also for all prostate cancer patients to be tested, newly diagnosed. Also, all pancreatic cancer patients and all ovarian cancer patients, they should be tested. So there's certain things that we looked at. We look at diagnosis. We look at the age when the patient was diagnosed. We look at their family history, and it's not just having family history of any type of cancer, because sometimes we ask the patient, well, tell me more about your family history. And they tell me, oh yeah, I have a family member that died of lung cancer, but they were heavy smokers.
Sure, right.
But if they tell me, by the way, I had a sister that was diagnosed in the 30s, and I had another sister that was diagnosed with ovarian cancer, right? Or my father was diagnosed with prostate cancer. Those are things that should make an oncologist think about the possibility of genetic testing for that patient.
So it sounds like one of the keys here is to have those conversations with your doctor.
Correct. And medical oncologists are actually trained to be able to answer those questions. So somebody who wants to come and have genetic testing, they can make an appointment and decide whether they should really fit the criteria, whether they have the right patient, if they're the right patient, even if they've never been diagnosed with cancer before. Remember, there's two, that's the part that we want. We want to be able to catch people who are at high risk early on before they get diagnosed. So either a patient who has been diagnosed in the past and they want to be tested, we talk to them, we tell them, yes, you probably are at high risk. There's a good chance that you have the genetic test positive, that you have some sort of mutation, or someone who's never been diagnosed before, but they're concerned because they have a very strong family history and they want to be tested. We get those patients all the time.
Yeah. And this genetic testing, I think you anticipated my question, it can show you signs before, for example, the annual mammogram can.
Well, it's a little bit different than that. So It doesn't show you signs. What it's telling you is whether the specific patient, right, is going to be at high risk of developing cancer throughout their lifetime, right? It's very specific because we look at different genes. These are genes that you and I have. Everybody has them. These are genes that are oncogenes. These are genes that are there to control the growth of cells, essentially to prevent your normal cells from developing into cancer. But when those genes get mutated, right, and based on the mutation that is present, then we have, and based on data that has been collected over the years, we know for that specific patient what's going to be the risk of developing either breast or colorectal or ovarian or prostate if it's a male, or male breast cancer or pancreatic cancer, right? The other day I had a patient that I tested her thinking that she was going to have a high risk of developing breast cancer. She already has been diagnosed with breast cancer. Interesting enough, she did not test for a gene or a mutation that would put at risk of breast cancer, but we found out that she's at risk of developing melanoma, which is, a very lethal type of skin cancer. So what we did was we sent the patient to dermatology to be seen, to be screened.
And then she would know with that to have her regular follow-ups with dermatology to make sure she's not developing any abnormalities.
Right. And Ray, you're right on time. I wanted to bring you into the conversation. As the lead LPN here, you coordinate, my understanding is you coordinate the genetic testing.
Yes.
Can you talk
correct.
a little bit about that process?
So once the patient comes in and Dr. Rivera and the patient decide that this is the best course of action, we have the patient actually head right over to our lab with a fancy little box. They have a very easy blood draw, and then they return the box to us, and then we send it to a company that does the testing for us. And then those results come back usually within 14 days-ish. Once those results come back, depending on what those are, if it's negative, it's usually a quick phone call to the patient saying, hey, everything came back negative, nothing to be concerned about at this time. Or if they did come back with an abnormality or anything like that, we would have them come back and have more counseling with Dr. Rivera.
Mm-hmm. And what do those next steps look like if it is positive?
So if it were positive, usually we're able to get patients in fairly quickly, usually within 3 to 5 days, and not generally longer than that. And then they would talk with Dr. Rivera about the risks that their mutation has. With some of these companies that we use, they also have genetic counselors that are available. I believe one of our companies, if they've tested positive, they will test family members also. Most of these are covered by insurance, and the companies we use are very good about financial assistance if it exceeds a person's budget.
Yeah, you anticipated that question as well. No, that's a good thing. We always have to talk about it. It's the unfortunate reality of medical care.
So what I was going to say also is the fact that, like Ray was saying, once we know that the test is back and the test is negative, they just give the patient a call. We don't give positive results on the phone. They meet with me because medical oncologists are trained in being able to do genetic counseling. Some hospitals do provide on-site genetic counselors there. Those are very difficult to find. It's not like there's a lot of genetic counselors out there. And some of the companies that have their own genetic counselors. So if they want to specifically talk to a genetic counselor, we give them a number and they can call, right? And they can help them decide what would be the best thing for the family members, right? When I meet with the patient, then I talk to the patient in terms of the risk. You have to keep in mind that there's different situations that we're doing genetic testing here. We do it in patients who perhaps have a high risk of developing cancer or that we suspect they have a high risk, but who have never been diagnosed, okay? But we do it also in patients who already have a diagnosis, right? Especially if they're newly diagnosed, to help them decide what will be the next step in their treatment path for their diagnosis. The perfect example is breast cancer patients. We have breast cancer patients that come in, they get diagnosed with breast cancer, and I like to see them first, and most medical oncologists see the patient first, because if we suspect that the patient is at high risk of developing breast cancer that has some sort of genetic predisposition, then it will help the patient decide what type of surgery it's going to have. Does the patient want to have breast conservation, or the patient wants to have bilateral mastectomies, right? Wants to have a mastectomy or the one that is being diagnosed with, and a prophylactic mastectomy of the contralateral breast, of the opposite breast. It's going to help the patient decide, do I need to have my ovaries removed at one point, right? Some patients come where they already had their ovaries removed, but some patients are not. If it's a younger patient, I never had children before, do I want to have children now and then wait to have my ovaries removed? All that a patient's going to need to have an idea of what would be the next steps.
If you're just joining us, I'm TG LaFredo. This is Focus on Your Health, and this week on the program, it's the Best of 2025, Part 1. This week, we're focusing on genetic testing for cancer. And if you have questions about genetic testing at KRMC, you can call 928-692-4666. That's 692-4666. Sarah Brady is a longtime nurse, and as you will hear in our second segment, the women in Sarah's family have a history of cancer. She shares her experience with genetic testing and the difference it has made in her life.
In 2010, about 5 months after I married my husband, my mom was diagnosed with stage 2 breast cancer, and it was highly aggressive, triple negative breast cancer. She was 55 years old at the time. She was working as, I believe, a vice principal of one of the schools here in town. She'd been an educator for 30 years here in the Kingman area, most of that time. So in October, during Breast Cancer Awareness Month, the school district brought in the van for all the teachers at the school to have their mammograms completed. She had had a mammogram done the prior June. So just a few months earlier, she had had a completely negative routine mammogram completed. In order to set a good example for all the teachers in her school, she went on the bus and got her mammogram done again, even though she wasn't due and didn't need it yet. And that showed something that wasn't there before. And so as the workup continued through the health system, she discovered that she had this stage 2, very rapidly growing breast cancer. If she hadn't gotten that test in October, she would have been far advanced by the time she showed any symptoms. Completely a blessing that they had the van there and she was able to capture it. But she had to go through a lumpectomy, biopsies, having a port placed. She had to get months of chemotherapy and months of radiation and ended up making a full recovery. But the process is ugly. It's not fun. It comes out of nowhere, it seems like, and you're just really, really ill while you're trying to fight this thing. So I'm grateful that she had that done and had that tested and that she was able to make a full recovery from that. She's since passed away in 2018 from a different unrelated illness, which was awful. But at that time, my older sister, who lives across the country, decided to get genetic testing done to see if we had the BRCA gene. And what made her do that is watching my mom go through the, cancer diagnosis, the chemotherapy, but also on my mom's side of the family in Southern Illinois, she had multiple aunts, a sister, nieces, cousins, and a significant percentage of these women in their 50s all had aggressive breast cancer diagnosis. And so my sister did this testing and was positive for the BRCA2 gene. She called me and said, you need to get tested. So I met with Dr. Rivera, who's amazing, so efficient, so intelligent, great bedside manner, just wonderful. I can't say enough good about the man. He was wonderful. He ordered me a test. They mailed it to my house. It just required a spit sample and cheek swab. I mailed it back out and got my results, which said that I had the BRCA2 gene as well. And that's what sparked this whole healthcare process. His recommendation was, decide if you're finished having children. You really should have a double mastectomy, and you should consider having a hysterectomy and ovaries taken out, so an oophorectomy as well. My husband and I gave that a lot of thought and a lot of prayer for probably a year before we made a decision together that this was the right thing to do. I did not want to go through this. What I watched my mom go through, what I've watched so many other women go through, both in my family, in the community, everywhere, especially at a young age, because my mom was in her 50s, but you see women in their 40s and 30s and even 20s now being diagnosed with breast cancer. But there's ways that you can get yourself checked and do the preventative things. So started the process with all of these providers, met with my GYN at the time, was Dr. Tedesco, and talked with him about the hysterectomy piece of it. I was in my early 30s, already had 2 kids. We knew we weren't having, any more children, so family planning wasn't an issue for us. Had to meet with a plastic surgeon and then a breast health surgeon as well, and she was in Sedona. So it took about a year in getting appointments with all of those specialists, meeting with all of them, discussing what I should do, what is their recommendation, what would testing look like if I didn't go through with having surgeries. And at the time, and it probably still is the recommendation, I would have had to have a mammogram and a breast MRI every 6 months, like overlapping. So I'd have a a mammogram, and then 6 months later have the MRI, and then 6 months later mammogram, and then 6 months later MRI. And I really didn't want to do that. I had several mammograms, but I did the MRI once, and I just thought, this really isn't worth it to me because the risk is still there. I'm just being screened more frequently, which is great. So decided to move forward with planning surgeries. And in January of 2020, I had the double mastectomy first. And I needed to have that first because I was still very young and my docs were really not wanting to put me into early menopause. So in order to not go into early menopause when you have your uterus and ovaries taken out, you have to be on hormone replacement. You can't be on hormone replacement, or shouldn't be, when you have breast tissue, because that can actually increase your likelihood of growing cancer. So that had to be done first. So I did that first. I had that done in Sedona, and I had to coordinate with the plastic surgeon at the time. Everything went beautifully, beautifully. I cannot say enough good about that experience, but it took 8 weeks to recover before I could go back to work. So we really had to plan well, my family and I, which we did. I was able to go back to work. Since then, so 5 years down the road, I did have 2 small revision surgeries from that, and then nothing else. It's all good after that. So that was January of 2020, the first one. In November of 2020, I had the hysterectomy and oophorectomy, so uterus and ovaries taken out. That was done here in Kingman. Great experience here as well. Can't say enough good about the surgery team, about my doctors, my nurses, all the surgical staff. Everything was great. And then I was able to start hormone replacement after that. I have had no issues with any of that since then. I have extreme peace of mind after all of that.
Sarah, if a friend of yours came to you and said, I just had genetic testing and it showed the BRCA gene, and what kind of advice could you offer me? What would you say to her?
My initial response would be to just be there. Sometimes it's just, I understand and I'm here. What are you thinking? But if they were said specifically, what is some advice that you can give us? I would say start scheduling some appointments to gather information. And once you have all the information, make yourself a plan. What's right for you? Is it screening every 6 months for a number of years until whatever time comes? Is it, no, I think I want to move forward and start going down the surgery path? Great. I can help point you in some directions for that and give you some encouragement. Even though you have the BRCA2 gene, it doesn't mean that you have to do something today, but you do have to do something soon. So whether you make a decision to have screenings done or you make a decision to have surgery, you don't have 5 years to make that decision. Shameless plug from a nurse of 18 years and in healthcare for 24 years. If you have women in your life between the ages of 20 and 60, encourage them to take ownership of this part of their health. Go talk to a medical professional, get a recommendation, and then make a decision. And just know that whatever the decision is that you make, as long as it's you're getting screened and being checked, even if it's self-checks and mammograms for the rest of your life, that's enough. Just pay attention to it and try and avoid being the person that strikes, if you can.
That's Sarah Brady, a longtime nurse, sharing her experience with genetic testing. If you have questions about genetic testing at KRMC, you can call 928-692-4666. That's 692-4666. And that is the program. That's the Best of Focus on Your Health 2025, Part 1. Please join me next time for Part 2. I'm TG LaFredo. Thank you for listening. We'll catch you then.